Okay, let's dive into this. Welcome back, everyone. Today, we're jumping right into a brand new explainer. We're going to be walking through a really highly curated set of clinical study notes to completely demystify the management of HIV. Basically, we're taking pages and pages of complex medical data and translating them into a clear, actionable clinical crash course. So let's get started.
Right out of the gate, check out this number, 83%. In our clinical notes, there's actually a handwritten double star right next to it, which is a massive visual cue that this is a high-yield clinical fact. This 83% represents the risk factor attributed to men having sex with men. You see, before we can even begin to treat a virus, we really have to understand the populations that are most impacted by it. Getting a firm grip on our patient demographic, that is absolutely our first critical step in clinical management. To get there, here's our roadmap for today. First, understanding risk factors. Second, the stages of progression. Third, testing and diagnosis. Fourth, pharmacologic therapy. And finally, number 5, prevention and prophylaxis. Let's start with Section 1, understanding risk factors. Because honestly, before we can look at what the virus does microscopically inside the body, we absolutely have to look at how it spreads out in the real world. So looking at the key risk factors, some of these you probably already know, right? Unprotected sex and IV drug use, specifically sharing needles. Those are widely recognized. You'll also see some historical risks noted, like receiving blood transfusions prior to 1985. But take a really close look at the bottom of that list. Healthcare worker. It is explicitly listed there. This is just such a vital reminder that occupational exposure is a real, everyday risk, and it perfectly sets up exactly why we need to talk about standard precautions a bit later in this explainer. Moving right along to Section 2, the stages of progression. Now, what's really interesting about this next part is what actually happens inside the body after an exposure occurs. Seeing this visualized is brilliant. It's essentially a complex microscopic battle playing out in physical vials of blood over time. This captures the most fundamental concept of HIV progression, which is the inverse relationship between the virus and the immune system. See the little red spiky HIV particles? As they actively replicate and increase their numbers over weeks and years, watch what happens to the blue CD4 cells. Those are our crucial immune defenders. They just plummet. As the red goes up, the blue goes down. It's a really simple visual, but it captures the entire pathology of the disease perfectly. Clinically speaking, this whole timeline shifts dramatically across 3 distinct stages. Stage 1 happens just days to weeks after exposure, and it usually presents as a really acute flu-like illness. We're talking fevers, body aches, sore throat. But then the timeline shifts entirely. Stage 2 is this massive 8 to 10-year window where the patient is largely asymptomatic. Think about the real-world impact of that for a second. The virus is actively replicating inside, but a patient might feel completely fine for a full decade, potentially spreading it without even knowing, before eventually progressing to Stage 3. This right here is exactly why widespread routine screening is so incredibly vital. And that brings us to Stage 3, acquired immunodeficiency syndrome, or AIDS. There is a very strict clinical threshold where HIV officially progresses to AIDS, and it's when that blue CD4 cell count we talked about drops below 200 per cubic millimeter, or less than 14%. At this severely depleted level, the human body just can no longer fight off opportunistic infections. This is the critical line we are constantly fighting to prevent a patient from crossing. Which brings us to Section 3, testing and diagnosis. So, how exactly do we go about finding a virus that is so notoriously good at hiding? Well, we have 2 primary tests, and it really helps to use a fishing net analogy here. The ELISA test, that's our wide screening net. It's super common, but it takes at least 21 days for the HIV antibodies to actually show up enough to be caught in it. Now, if the ELISA net does catch something, we don't just stop there and diagnose. No, we move to the Western blot. The Western blot is our specific, highly accurate confirmatory test. It takes a bit longer, usually about a week for the results to come back, but it scientifically confirms that initial ELISA screening. But what if you're dealing with a transient patient? Someone who might not come back to the clinic a week later to actually get those Western blot results? That is exactly where the rapid HIV test, like the OraQuick, is incredibly useful. You get immediate results. But look really closely at the clinician's handwritten note there. Home test, arrow, confirm. The clinical rule remains absolutely strict. A rapid test must always be confirmed with a second type of test, no exceptions. Once a patient is diagnosed, we use 2 vital tracking metrics. First is the HIV viral load, which measures the actively replicating virus in the body. If that viral load is greater than 5,000 to 10,000 copies, we need to initiate treatment immediately. Conversely, we have this CD4 count, which monitors the health of the immune system itself. We check the CD4 count every 3 to 6 months because that number directly guides our ongoing treatment choices. Okay, let's move right into Section 4, Managing with Pharmacologic Therapy. We have the diagnosis, so the crucial point is, how do we fight back? We use combination antiretroviral therapy, or CART.
And right here is our ultimate clinical goal, 90%. When a patient is on CART, 90% of those doses must be taken exactly on time. Why? Because this virus is relentless. If doses are frequently missed, drug resistance develops incredibly rapidly, which leaves us with far, far fewer weapons to fight it.
Now, as undeniably life-saving as CART is, we have to be real. It comes with some pretty severe challenges. It is expensive, it requires incredibly strict specific dosing regarding timing and food, and it involves taking multiple drugs every single day. Furthermore, the side effects can be really rough. We're talking things like anemia, neutropenia, and lipodystrophy, which is a condition that actually alters the way a patient's body uses and stores its fat. And this brilliantly illustrates the pharmacological tools we have at our disposal. Over on the left, we have trizavir, which contains NRTIs. Basically, these block an HIV enzyme called reverse transcriptase, preventing the virus from making new copies of itself, and it's taken orally twice a day. But on the right, we have Truvada. Now, this is fascinating. Truvada is actually used for pre-exposure prophylaxis, or PrEP. It's a once-daily pill taken by high-risk populations, like men having sex with men or IV drug users, to proactively protect themselves against the virus before they're ever exposed. Which seamlessly leads us to our final clinical step, Section 5, Prevention and Prophylaxis. Because, let's be honest, the absolute best way to manage HIV is to just stop the spread before stage 1 even has a chance to begin.
Remember those occupational hazards we mentioned earlier? Well, if a suspected high-risk exposure occurs, say a healthcare worker gets a needle stick, the clock is immediately ticking. Notice the incredibly tight window here. AZT or CART therapy absolutely must be started within 2 to 72 hours. Education and immediate, decisive action are literally life-saving in these scenarios.
I want to bring our clinical journey today to a close with this direct, handwritten note from the source material. It says, medication can keep HIV at stage 2 for decades. Just really think about that for a second. What was once a rapid, fatal diagnosis can now literally be halted in its tracks. Through strict adherence to modern pharmacology, we can suspend the virus in that asymptomatic stage 2 for decades. It is an absolute medical triumph.
We've seen the data, we've looked at the diagnostics, and we've explored the incredible power of antiretroviral therapies. But, it leaves us with a really profound thought to ponder. If medication and strict adherence can physically halt this virus for decades, is the next crucial frontier in medicine eradicating the social stigma just as effectively as we eradicate the viral load? Thanks so much for joining me on this explainer. Keep learning, and I'll see you next time.